Okay. All right. Well, welcome everyone. Thanks for joining today. My name is Julia Masters. If I haven't connected with you, I am the program manager for the Microgrids for Community Resilience Grid program. This is kicking off our first series of webinars during our application window this spring. And this webinar will be mostly covering public health, extreme heat and extreme weather, and the added value of grid resiliency and microgrids. So we're really excited to have some great speakers for you today. Without further ado, I will get going on my part of the presentation. Yeah, so we will be recording this and it'll be posted to the CRO's website. If you have any questions, feel free to throw them in the chat. So our agenda today, we're going to be talking a little bit about the MCR program, and then I'm going to be handing it over to my colleagues at the Colorado Public Health and Environment Agency, and they're going to be talking about extreme heat and the built environment. And then we're really lucky to have Andrew here with us talking about grid resilience and public health and the microgrid projects that his organization is helping to launch. So a quick overview of the MCR program. So some folks may be aware, we have a grant program from the state that is funding community level climate resilience through planning and construction grants. On the right here, you can see an image of a microgrid. If you're not familiar with the basic overview, you can see on the left side of the image, we have our renewables, our battery, and our generator, which all kind of feed into the microgrid interconnection, which then can get connected to the utility grid and feed energy and resilience into commercial, industrial, residential, or EVs. So that's kind of the general overview of how a microgrid can operate. There are lots of different ways that it can be designed and optimized. And we can talk about that a bit more if folks have questions. And we have just a general definition here in that blue box, a group of interconnected electric loads and distributed energy resources that can be connected or disconnected from the grid to enable it to operate in either grid connected or island mode. And we'll keep going. So we have funded 8 planning grants thus far for the MCR program. We've had 2 full rounds of funding. We're finishing up kind of the contracting piece of the second round of funding, and we should have some public announcements soon around who we're granting to. But on the right, you can see the locations of those 8 planning grants funded in round 1. A pretty wide range of geographic diversity around the state. And I just wanted to call out some of the kind of the ways we think about microgrids as the state and the benefits of them. So in this first upper left-hand box, I'm thinking about emergency management and communications resilience. So an example of this, San Miguel Power has a solar and storage microgrid that is dedicated to supporting the utilities infrastructure. So they had an experience a few years back where they had an avalanche and an outage, and they couldn't communicate to any of their customers about when the grid would go back on, anything around that. So this kind of backup power helps with communications and emergency management. Next to the right, Poudre Valley Rural Electric Association is thinking through microgrids in that economic resilience portion. So they are exploring a solar and storage and backup generation microgrid in the town of Livermore, which will support both the fire station and a number of community assets around there if and when there are power outages. And then finally, the city of Delta out on the western slope is exploring adding heat and power, or otherwise known as CHP, to support the community's grid in the event of a prolonged outage. This is also an area that we think about reducing the risk of EMPs or electrical magnetic pulses is something that we're thinking about with grid resilience and the benefits of having these distributed energy resources as well. And just some high level awareness for folks on the call. The state is doing a lot around grid resilience funding. As I mentioned, the MCR program, which is House Bill 221013, set aside 3.5 million to support rural communities and develop microgrids. Then the federal government DOE released their formula funding for states, and the Colorado Resiliency Office and the Energy Office have partnered together on that work. You can see some of the numbers of funding here. But there are 5 years of funding. We've had years 1 and 2 have been administered already to the state. We're working on year 3, and a quick plug for later today, we will be having a public meeting on our year 3 allocations. If you're interested in joining that, you can check that out on the website. And then finally, the Colorado microgrid roadmap is in process. That was set statutorily, and we've completed 1 round of stakeholder engagement. And we're in the process of kind of developing that that draft, and will be available for public comment next year. And then just a quick overview of the funding that will be available this round. We are opening our grants next week, a week from today, actually. And we will have planning, construction for generation, and construction for solar and for storage and controller available for a total of 11.1 million. As you can see here, there are some different eligible applicants by funding stream. And one thing I'll call out, this is pretty self-explanatory, and we'll share these slides with folks. If you are interested in the storage and controller element of the funding, and you are a non-utility, we've expanded the eligibility to local governments and public or nonprofit community-based anchor institutions. This is really exciting. We're looking forward to being able to partner with those types of entities. And just a quick call out for the match requirement on that piece. If local governments and anchor institutions are applying, they will have 100% cost match. However, if they do have any sort of existing solar storage anywhere, not on the project specifically, but just kind of anywhere as an entity, we can work with DOE to reduce that match from 100% to 1/3. So just keeping that in mind, if you're thinking through how we can best optimize this funding opportunity, just some strategic things there. A quick overview of community anchor institutions. We're thinking about these as schools, libraries, hospitals, places that are providing emergency medical services, and organizations that support marginalized communities. So there's a lot of different ways that communities can think about what their anchor institutions are, and we're really trying to emphasize the benefit of having grid resilience integrated with these community anchor institutions so that there are multiple benefits to the community, not just grid resilience, but the ability for folks in the community to know where to go in the event of an emergency, to charge their phones, to have refrigeration for their medicine, things like that. And then this is my last slide, just some example grant projects for contemplation if you're thinking about applying. Planning grants where we can look at feasibility, pro forma engineering studies that kind of evaluate existing infrastructure and develop recommendations for how to design a microgrid. And then for construction and implementation, we are looking at projects that are technology agnostic and can include funding for storage, controllers, electrical components, or replacing old generation components with new. So that's thinking about like if there's an old solar a solar system and there's damage to it, we can replace that with the federal money. Otherwise, new generation is eligible under the state funding. So we will have more MCR specific webinars in the upcoming weeks where we'll dive into this a bit more. This is pretty high level, but just wanted to kind of flag some of those elements for folks starting to think about if they are interested in applying this round. And with that, I will turn it over to Kate and her team for their presentation.
Great. Thanks, Julia. Maybe we'll start with a quick round of introductions. My name's Kate Townley, and I lead the Healthy Communities Unit in the Prevention Services Division at CDPHE. And I can pass it to Molly real quick.
Thanks, Kate. Yeah, hi. I'm Molly Middleton. I'm an environmental data analyst, and I work on the Colorado tracking program. I'll pass it to Henry.
Thanks, Molly. My name is Henry Mitchell. I'm the Deputy Director of the Office of Emergency Preparedness and Response, and I run the public health operations as well as our DOC. So pleased to be with you all here.
Thanks. And we're going to cover kind of the who, what, and where of extreme heat and health. We'll do an overview of some data analysis on the health impacts of heat. And we'll talk about the extreme heat response plan for access and functional needs, as well as long-term care facilities. Next slide. Excuse me. So extreme heat, that's when temperatures are well above normal conditions. And extreme heat events are consecutive, unusually hot days and nights. It's context specific, so we don't have like an exact definition of what extreme heat is for different parts of the state. Heat is important to public health because it's a leading cause of weather-related deaths in the United States, and it's a growing public health threat here in Colorado. As temperatures rise across the state, heat illness and death could become more common. However, heat-related illness and deaths are preventable, and heat-related illness can be prevented through hydration, access to cooler temperatures such as air conditioning, shade, or public water amenities. And also it's preventable by limiting exposure to heat. Next slide. So really anyone can be at risk for the adverse health effects of heat, but some individuals are more at risk. And Henry will go into this more. But people who are access and functional needs are more susceptible to heat-related illness and death because of their reduced physical capacity to regulate body temperature. And the next one. So in addition, our outdoor workers are more at risk, and that's due to high exposure on the job site, and they're often doing high exertion work at their jobs. And also folks who are socially isolated and or living or working without air conditioning are also more at risk for extreme heat. Next. Sorry about that. So these are maps from the Colorado Climate Preparedness Roadmap. We're seeing that all parts of the state are experiencing more heat days. The southwest corner of the state and San Luis Valley have experienced kind of the greatest annual warming. And then our heat waves, or what we call periods of extreme heat, those have increased in most areas of the state, with the biggest jump in the northwest and also the central western slope regions. And in the future, we expect that extreme heat could affect Colorado's eastern plains the most, with up to 20 additional days per year exceeding 95 degrees, and that would be by the year 2050. We also anticipate more heat in our urbanized areas because they may not cool off as much at night. Next slide. There's also places where people are more at risk for extreme heat. Access to cooling is viewed as the most effective way to prevent heat-related illness, but there are many homes and work sites and care facilities that may not have access to cooling. And most current cooling systems are energy intensive, and that can increase our greenhouse gases. Sorry about that. That can increase our greenhouse gas emissions. And also they could be too expensive to install or to run for people who have low incomes or are on a fixed income household. Next slide. So the built environment and the design of our communities can also impact our health and our exposure to heat. So this graphic shows kind of all the things that we'd want to see in a healthy, equitable community. The gray boxes include elements of healthy communities, And if you look at the bottom of those boxes, you can see the health benefits attributed to those elements. All of these different elements impact our physical and our mental health. And as from the public health perspective, we look to partner with local communities, with DOLA and other sectors to really influence how our communities are designed and how that can impact our health and our exposure to heat. Next slide. Going to walk through one example of an element of a healthy community and how that can have health and climate co-benefits. So one of these elements is parks and community spaces. Some of the health benefits we can see with parks is increased physical activity, which can reduce our rates of chronic diseases. It can also, with having an increased shade tree canopy, that can reduce our UV exposure and help with rates of our skin cancer prevention. And access to parks and green spaces can reduce our stress and lead to better mental health. And they also encourage more social interaction and connectedness. And then we also see climate co-benefits from parks and community spaces and our tree canopies. For protection for heat, it can reduce our risk of heat-related illness. Our green spaces don't absorb as much heat as our paved surfaces, and that can reduce the heat in those areas. In addition, our tree canopies can create shade and create more of a cooler microclimate in those areas. And this can also reduce our overall reliance on air conditioning. Next slide. From public health, we really want everyone to experience health and climate co-benefits, but not everyone or every neighborhood has the elements of a healthy, equitable community. We've seen structural racism in the form of land use, lending, and housing policies in the past that have created inequities in our built environment. And that's led to health and wealth gaps in many of our communities. And that's leaving some of our communities more vulnerable to the health impacts of heat. Next slide. This is an example of inequities in the built environment and how that can lead to heat vulnerabilities. Those of you from the metro area may be familiar with Denver's inverted L, what you see in the red there. The areas along the inverted L experience inequities in the built environment. So an example of that is the tree canopy cover. The areas along the L have less trees and experience greater vulnerability to extreme heat, which you can see in the purple on the right. And I'm going to pass it over to Molly, who's going to share how we can use some of our health data to show these connections between the built environment and the health impacts of heat.
Thanks, Kate. Yeah, hi everyone. So like Kate said, built environment inequalities can drive climate vulnerability. Oh, we can go to the next slide, sorry. Yeah, so we wanted to look at one example of this relationship in Denver. Just looking at the association between historic residential redlining and present day burden of heat-related illness. So I'll do a brief background on redlining. I think we all understand what it is, but just to be specific, in this study, redlining refers to the discriminatory practice of categorizing neighborhoods by perceived investment risk, where the HOLC mapped neighborhoods by risk according to one of 4 color-coded letter grades, like you can see on the map on the right. So A, B, C, or D. A represented the best grade, D represented the worst. And these grades were discriminatory because they were based largely on the racial makeup of neighborhoods. So neighborhoods with larger proportions of Black, immigrant, and Jewish families and residents were explicitly downgraded. Next slide. So redlining diverted funding and resources away from low-income and non-white neighborhoods, resulting in decades of disinvestment for these areas. Aronson et al. Found that redlining has perpetuated racial segregation and resulted in less homeownership, reduced home values, and lower credit scores. Research has also shown that there are numerous health outcomes that disproportionately burden residents of redlined areas, like those listed on this slide. And then also research is showing that redlined areas may be more vulnerable to heat than non-redlined areas. So in one study of 108 urban areas across the US, they found that redlined areas have statistically higher land surface temperatures. Next slide. So knowing that health outcomes tend to be poorer and environments tend to be hotter in historically redlined areas, and also knowing that we will continue to experience more extreme heat events as a result of climate change, we wanted to investigate whether there is an association between historical residential redlining and present-day burden of heat-related illness in Denver. Next slide. So just briefly, some methodology. So to measure heat-related illness, we calculated 5-year age-adjusted rates of ED visits due to heat-related illness using data from the Colorado Environmental Public Health Tracking Program. The unit of analysis in the study is census tract. So we then linked these rates by census tract to data on HOLC grades mapped to present day census tracts in Denver. And then we included poverty, race, education, and health insurance status as covariates because those have been identified in literature as social vulnerability factors that contribute to population heat vulnerability. Next slide. So this map shows census tracts included in the study. There were 72 total included in the study. And the color indicates the HOLC letter grade that accounts for the majority of the tract area. And as you can kind of see again, it's present day census tract, so the shapes look a little bit different, but you still kind of see that inverted L pattern in the tracts that were included in the study. With a lot of the red line tracts kind of following the highway too is something I noticed, I-25. Next slide. So in bivariate analysis, we saw that proportions of all social vulnerability factors increased as HOLC grade worsened. You can see in the columns A, B, C, and D, D's highlighted in red. And those differences were statistically significant using ANOVA. And then on the bottom row, we have our HRI ED visit rates per 100,000 population. And you can see also that kind of as you go from A to D, those rates tend to increase. And that was also significant using ANOVA. Next slide. So over the next few slides, we'll kind of visualize what was just in that table. So this is showing poverty by neighborhood HOLC grade. So you can see as you move from those A tracts to D graded census tracts, the percent of the population living at less than 200% of the federal poverty level tends to increase and is highest in the red line tracts. Next slide. This slide shows the percent of the population that is non-white by census tract by HOLC grade. So as you can see in the red line tracts, that percentage is a lot higher as compared to A, B, and C tracts. And this is something that we would expect to see as a result of the segregating effect that research has shown that redlining has had on communities. Next slide. This slide shows educational attainment differences by neighborhood grade. And so you can see that in the red line tracts, the percent of the population over age 25 without a high school diploma tends to be a lot higher than the non-red line tracts. Next slide. This slide shows percent of the population living without health insurance by neighborhood grade. It's sort of less dramatic than some of the other covariates, but you can still see that kind of general increase as you go from A to D graded tracts. Next slide. And then finally, this slide shows heat-related illness rates by HOLC grade. And so you can see again that kind of similar trend where the tracts with the highest burden or the highest rate of heat-related illness tend to increase as you go from A grades to D grades and tend to be highest in the red line tracts in Denver. Next slide. So we then used multiple linear regression to assess the relationship between heat-related illness rates and the percent of the census tract area that's redlined. So kind of looking at here how redlined tracts are. And we saw that that relationship was significant in both unadjusted and adjusted models. So ultimately what we saw is that for every 10% increase in redline census tract area, the heat-related illness rates increased by 4.5 per 100,000 people. And that's after controlling for poverty, race, education, and insurance status. Next slide. So yeah, just for a little bit of visual comparison, on the left, we have again that map of these study census tracts included in Denver colored by their HOLC grade. And then on the right, what we have is the heat-related illness ED visit rates by census tract mapped. So the darker the census tract, the higher the rate. And what you can kind of see here is a lot of overlap in kind of more darkly shaded census tracts and red line tracks, and also C-graded tracks, and especially in those tracks that kind of tend to follow the highway, and especially concentrated in that kind of central north part of Denver, like the Five Points area. Next slide. So some takeaways here. We saw that historical residential redlining was associated with increased age-adjusted rates of ED visits due to heat-related illness in Denver. These findings suggest that historical discriminatory policies may influence present-day heat-related disparities in Denver, and we feel that the findings support the need for equity-based heat mitigation and outreach efforts in Denver's historically redlined neighborhoods. Okay, how am I doing on time? I think I have a few minutes left. So I'll kind of go over this next one briefly. So this next analysis we wanted to share, we recently conducted an analysis to better understand the relationship between heat and overall morbidity in Colorado during the heat season. So in the last, in the redlining analysis, we were looking at specifically acute heat-related illness. But here, we realized that we have well-established surveillance on heat-related illness, but we have a limited understanding of the impact of extreme heat on overall morbidity or all-cause morbidity in Colorado. Even though that there is substantial literature documenting the relationship between heat and higher risk of morbidity around the world. So we looked at our data to better understand this relationship in Colorado. Next slide. So we wanted to measure the association between temperature as maximum daily heat index and overall morbidity as all-cause ED visits. So to measure temperature, we calculated daily maximum heat index using NOAA weather station data across 7 weather station sites in Colorado, as you can see on the map. We derived maximum daily heat index for each day of the heat season, which is May through September of each year. We included the most recent years of data that we had available, which were 2016 through 2022, but we made the decision to exclude 2020 and 2021 due to the pandemic effects on ED utilization. That just felt like something we wouldn't be able to control for. And so we included 5 years of study data in total. And our 7 study sites included Denver, Colorado Springs, Pueblo, La Junta, Trinidad, Durango, and Grand Junction. So we have these sites and we have this weather station data, and then to identify people who are exposed to the temperatures measured at the weather station, people who live around the weather stations, we created, as you can see in purple on the map, this 15-mile buffer around each weather station, and then included all ED visits for people that live in census tracts that intersect with those buffers at the site as the site's study population. So ultimately, these study sites represented a total population of about 1.7 million, according to 2019 ACS 5-year estimates. Next slide. So what we found, so just briefly on the methodology, we used a distributed lag nonlinear modeling framework to estimate the association between heat and ED visits for each of the 7 sites. And then we pooled those site estimates to create a meta-analytical model. So what we're looking at on this slide is the meta-analytic summary estimates of the association between maximum daily heat index and all-cause ED visits on the same day relative to 70 degrees. So you can see this line surrounded by the kind of gray confidence intervals. The risk appears to kind of gradually increase with temperature and then maybe plateau at higher temperatures a little bit, but it's hard to say. It could also just be a lower frequency of data points. Could also be, as some other researchers have speculated, behavior changes during extreme heat, like maybe people who exercise outdoors are more likely to stay inside once it hits triple digits as compared to when it's in the 90s. We can only speculate, but what we're seeing here is that the risk at 95 degrees as compared to 70 degrees is about 7% higher, and the risk at 100 degrees compared to 70 degrees is about 8% higher. So they're not too different. And this is for same day ED visits, just to note. So next slide. So this modeling framework also allows us to measure lagged effects or delayed effects in addition to same day, like we were looking at on the last slide. So on the last slide, we were looking at lag day 0 or same day, but on this slide, we're looking at lag days 0 through 7, or the cumulative impact of heat over a week. So this figure shows the cumulative risk of all-cause ED visits across temperatures over 7 days. And what I'm seeing here when I look at this is that the cumulative risk is not really greater than the same day risk until temperatures hit kind of 95 degrees and above. So we're not really starting to see any delayed effects of heat until we get to those really high temperatures. Like for example, at 90 degrees, the cumulative risk and the same day risk are the same. They're both 6% higher than a 70-degree day. But once you get to 95 degrees, the cumulative risk is 9% versus the same day risk of 7%. And at 100 degrees, the cumulative risk is 11% greater than a 70-degree day. And at 100 degrees, the same day risk is 8%. So we're starting to see delayed effects once you get to temperatures 95 degrees and hotter. Next slide. So this is kind of showing what those delayed effects look like. So this is looking, instead of the x-axis being temperature, the x-axis is lag in days here. So this slide shows the relative risk at 95 degrees versus 70 degrees over a lag of 7 days. So as you can see, the line and the confidence intervals are significantly elevated from day 0 almost out to completely day 1. So it's kind of significantly increased for about a day, which you'd expect, and then it kind of decreases after, but still remains a little bit insignificantly elevated for about 3 to 4 days. Next slide. And this table just shows the relative risk that we just saw graphed in the previous slides at varying temperature thresholds. And again, just to kind of underscore the difference between the 1 day risk and like risk over a week. At 90 degrees, you can see it's 1.06, it's the same. And then at 95, that's where cumulative risk starts to be a little greater than same day risk. Next slide. So we then wanted to estimate the number of visits attributable to heat in our analysis across our study sites. So the left 2 columns show the fraction of visits in our study attributable to 95 degrees or higher, and the right 2 show the number of visits. So in total, what we saw is that across our 7 study sites, we estimated that a total of 11,944 ED visits for any cause over 5 years were attributable to days with a heat index of 95 degrees or higher, or for an average of about 2,400 visits per year. And again, the study site represents a total population of about 1.7 million, which I believe is about a third of Colorado's population. Next slide. So some key takeaways. So for all-cause ED visits, we saw that risk increased with temperature. We saw delayed effects at 95 degrees or higher, and those were significant for 1 day and then elevated and significantly for 3 to 4 days. We estimated that just under 12,000 visits in our study area were attributable to temperatures 95 degrees or higher over 5 years. And ultimately, results show that we do see significant risk, delayed health effects, and excess morbidity attributable to heat, starting at temperatures around 95 degrees. And I will pass it off to, oh, actually, sorry, one more slide, next slide. This is just a plug for if anyone's interested in looking at our Colorado heat-related illness data, here's the link to our current webpage. And then we are also working on making some improvements to our heat-related illness dashboard before the summer. So that will be coming soon. And I'll drop those links in the chat. All right, Henry.
Thank you, Molly. All right, so we want to go over our CPHE OEPR Extreme Heat Response Plan. It was developed over the span of a number of months, and the final product was finished and shared last year. It applies to extreme heat-related emergencies that may cause severe illness that require a response effort over a defined period of time within Colorado, right? So that's impacting our communities over a number of days or longer that we may have to respond to. The plan's primary focus is on the residents of long-term care facilities, as well as groups that are defined as having access and functional needs. We'll support these groups with education and resources, as well as high-level coordination during extreme heat emergencies. And the plan is linked here on this slide, as well as I believe another slide on our deck. All right, so what are access and functional needs groups? You may have heard the term way in the past, vulnerable populations, and then that moved to at-risk populations. But in the emergency management world, we really like to talk about folks who have access to functional needs, because it really speaks to them not having the things that they need. They don't have the resources that they need during an emergency. So therefore, they are groups that have access and functional needs because they can't access these things, right? So they're groups. They're those who need accommodations and modifications due to a temporary or permanent condition that limits their ability to take some actions in the event of an emergency. An access and functional need may be due to physical, sensory, behavioral, mental health, intellectual, developmental, or cognitive disabilities, other chronic conditions, injuries, limited English proficiency, or inability to speak English. They all may just simply have trouble accessing resources during an emergency. It could be folks who are agricultural workers, even, like college students who aren't residents of the state. They can be considered folks who have access and functional needs because they don't have the resources that they normally would if they're home with their families. All right, so as far as this plan, we look at public awareness and notification process. The extreme heat threatens, the extreme heat threatens public health and safety, economic prosperity, and communities and natural systems, but these risks are not well understood. Our goals are 3. We want to build public awareness about extreme heat through communications campaigns, and through this example of our infographic focused on extreme heat science and physiological impacts, as well as action steps and where to go for more information. We want to support actionable climate science and research to inform risk assessments and decision making. And then third is to improve accuracy and accessibility of heat modeling and data to inform decision makers. So this infographic is something that we distributed last year. We can pull it off and distribute it to you all as well. I believe it may be linked, but like I said, it goes over physiological impacts of heat, tips on like what to do, how to take action, and then also data about heat-related illness and who is most at risk. Next slide. So this plan, this action plan, or excuse me, this plan is activated in response to a heat advisory received by impacted local public health agency, impacted long-term care facility. It could even be the Department of Homeland Security and Emergency Management, or the NWS, indicating a heat advisory or an area within Colorado, at the discretion of leadership who judges that prevailing or expected weather conditions validate the plan's activation. We'll maintain situational awareness via coordination with local public health agencies, local emergency management, and long-term care facility administrators. And CDPHE can serve as a connection point between these long-term care facilities and local ESF8, which is our public health partners locally when needed, and connect LTCFs with local resources. This plan is now kind of under the umbrella of a larger plan, a heat action plan, which we are developing, which we will be able to present later. Next slide. All right, so we're still drafting the heat action plan. It's going to provide more structure for response for heat response activities. and look at things like risk, needs, resources, and findings from CDPHE's data group, the heat and health analysis. But for this long-term care facility plan, we're looking at these response activities, providing state-level guidance to local-level government officials on any identified needs that remain unmet, both regarding the long-term care facilities and access and functional needs groups. So that can include advocating for local officials to establish cooling centers, establishing methods for distribution of water, and assessing hydration needs or tracking the movement of impacted persons, right? So if there is an extreme heat event and, a certain county or region is impacted, we're activating our Department Operations Center. We're reaching out to long-term care facilities as well as local public health in that area, and encouraging them and advocating them to reach out to their local officials to establish cooling centers. We can also make that connection between local public health, long-term care facilities, and emergency management to do the same, to look at opening up, establishing cooling centers as well. And then looking at kind of the logistics piece of establishing methods for distribution of water if that assistance is needed. So advising folks on different ways in which they can acquire water for their community members, and then also tracking movement of impacted persons. That's all for me. Thank you.
Henry and Molly. So we threw a lot of information at you. Hopefully you have some more information on the health impacts of extreme heat, as we're anticipating more of that in Colorado. You have some great resources in terms of how to find some data for your community in areas where you may want to focus more on extreme heat, and access to some plans. We will get the link for the infographic and also share that in the chat with you. Thank you.
Great. Thank you guys so much. We have time for probably one question for the CDPHE folks, if anybody has something they want to ask. If not, we can turn it over to Andrew for his presentation. I think you should be able to share your screen, but let me know if you're not seeing it. Great.
Is it showing the full screen, Julia? Or
It's
is it
showing the
okay?
presentation mode.
Got it. Let me switch. Okay.
Great.
All right. Thank you. I'm always still 4 years in after COVID, I'm still having a problem with that slide show. Thanks, everybody. It was a fascinating presentation by the Public Health Department. Thank you all. And Henry, you're speaking my language. I'm a former emergency manager myself, having worked for many years at a large nonprofit based in California that supports medical facilities all around the world and community health centers in the US with medicine and medical supplies. And so I'm going to show a little video which gives a little background on me and why I turned from that into this idea of providing resiliency to critical facilities around our country. I personally have a bit of a focus on community health centers because that's who I know and that's who I worked with. But I started a company called Collective Energy that really helps all community serving facilities kind of understand their need for resilience and how to go about designing and installing a clean and resilient energy system. So I'll show a quick video. I know this is going to be recorded, so it'll be kind of shared around, and then I'll talk a little bit more. Natural disasters in our country are becoming more frequent, affecting more people, and lasting longer. And that inevitably leads to more power loss. And without power, a healthcare facility can't do anything. Medical records can't be accessed, refrigerated medicines go bad, and medical equipment can't be used. It has to truly shut its doors. Collective Energy was started to help the over 15,000 health centers across our country have resilient power. I've been responding to natural disasters all around the world for the last 12 years. Going to these medical facilities that have just gone through or still going through a power outage, 100% of the time it became their top priority to never have that happen again. These health facilities now have a problem that they need to solve. And the problem is they continue to lose power. And so what we're doing for them is to give them an easy turnkey solution so that they can focus on providing care to their patients, where we can focus on bringing them this clean power, this reliable power that's going to save them money over the long term. Any health center that's interested can come to Collective Energy. We can design a system for them, use a trusted installer to install the system on their building, and we can even pay for the system on their behalf. The goal is to have every health center across our country have a resilient and clean power system that also saves them money and helps our environment. Power is a basic need. Our dream is clean, reliable, affordable energy for all, and it's going to take the collective. Cool. So I know, again, I want to just preface again, I know that this amazing funding opportunity from this amazing office in Colorado is not just for health centers. So please, that's my focus, and it was a public health focus today. So I'm it's geared toward that, but it's incredible that it's available to other community serving organizations. And we have done projects with social service agencies, and recently a very cool one with a National Disaster Search Dog Foundation that trains search dogs to go into disasters. And now they're in a high fire area, and so now they're backed up with solar and battery. So anyway, but the background on a health center is, there's many of them across the country, and as you all know, and especially the public health folks, aggregated together, they'd be the largest healthcare safety net provider in our country. They're all nonprofits. They're all in low income, medically underserved areas. 95% of their patients are low income, 65% are racial and ethnic minority. And unlike hospitals, they've never been required to have backup power. And so that's the key. They've never been required to have generators, but now they're required to have electronic health records to see patients, and they're required to store vaccines and refrigeration. So while they're not inpatient, sort of critical life-sustaining equipment, they can't actually perform their services when they don't have power, because they can't even intake a patient without electronic health records. So I'm going to talk a little bit about the public health folks were amazing in their the numbers and the data forward. I have a few numbers in here, but also it's kind of from my background and seeing this all firsthand across our country every time I would respond to a disaster. So to set the stage, state the problem we're solving here and why this funding from the state office and why the infrastructure bill even did it in the first place, I think, is our country is experiencing more frequent power outages that are lasting longer and affecting more people. And for critical services like healthcare, obviously that doesn't work. And so we have a need both to, of course, update and upgrade our grid, but also develop localized microgrids that Julia mentioned at the start that can actually prevent this problem. I think our national grid went out 71% more from 2023 than it did in 2022. Obviously, different states are differently affected. I live in California. We're one of the least reliable power states in the country. Colorado is right around in the middle, about number 22 in terms of power reliability. And of course, as the social vulnerabilities that the public health department pointed out, these things don't affect everyone equally. People that are immobile, don't speak the prominent language, are old, are very young, are unwell, they have a harder time, dealing with power outages or like extreme heat. So this is part of that idea that while while the healthcare sector is trying to solve and treat these folks coming in with health conditions, the health sector is actually contributing a large part to greenhouse gas emissions and to climate change, that affecting their patients directly. And so, you know, not just the healthcare sector, all community serving facilities, you know, should be thinking about how to be more sustainable, more resilient. This is a slide about how, and I don't need to show this because it's about how climate change is impacting people's health. And again, an individual microgrid is not going to necessarily, you know, change the global climate change, but it is going to support a resilient community and a place where people can go if they need care, cooling, heating, things like that. Power costs are also going up. So again, I know this program is funding resiliency. You know, the corollary to that is generation with clean energy like solar. Critical facilities, nonprofits can lock in their cost of power, and which is going up again differently in different places. California went up 22% last year in PG&E territory, which is our biggest utility. I just saw in Massachusetts, their big utility went up 29%. So it's a way to fix costs for facilities that are very constrained on their budgets. And then finally, again, there's disadvantaged communities across our country that have long been at the receiving end of historically unjust and racist environmental policies. And we know where those census tracts are. There's 27,251 of them identified. And these are usually the areas where these critical facilities exist to serve folks in these areas. And so these are clearly the locations that should also now be the most resilient because of not only our historical policies, but what those policies have turned into in terms of people's well-being in these areas. So there's so many reasons why this matters. Again, continuity of healthcare is one. We saw that, I think in the slides, you know, increase in emergency room visits during power outages. It always spikes. That's typically not where we want the vulnerable folks to go, is to the ER. Not just for the cost of that, but for the, you know, volume of patients going in at one time. So we need other critical health facilities to stay open. Extreme heat, as we've talked about, rising temperatures leads to higher use of cooling, leads to more power outages. So we need hub anchor sites to remain powered so they can provide cooling or heating, obviously, depending on your location. In some places, water is provided with power. So I spent a lot of time in Puerto Rico after the Hurricane Maria, and water pumps, people couldn't get water in their communities because it was a pump in a well. And so that led to extreme illness and death. Refrigerated medicine, 50% of all new drugs coming out of our pharmaceutical industry are now going to be cold chain. So now we have a refrigeration need, which requires power. And again, resiliency hubs is a sort of a nationwide movement. I've done a lot of work in New Orleans, where a community lighthouse initiative is trying to build 100 resiliency hubs in locations across the city, churches, houses of worship, health facilities, community centers, so that no one in the city of New Orleans is more than a 15-minute walk from a resilience hub if they need to get to a place with power. So it's this idea and why this program's so amazing. Okay, so again, I'll breeze through this, but this is kind of I think helps conceptualize the issue of power and power loss. I lived in Haiti for 2 years after the earthquake in 2010. 85% of the country has no power. It's all run on diesel generators. I lived next to one for 2 years. It always broke. It was noisy. It was dirty. It's where my hatred of diesel generators came in. And the point of this is, for forever, we've always relied on diesel fossil fuel generation as our backup power source in our country. And we don't have to do that anymore. We have batteries. We have more reliable, cleaner ways to provide backup power. In Oklahoma, I was responding to the tornadoes there, and this idea of a tornado, which is kind of first time I saw this, that a swath of a tornado can be very narrow and really affect, one house and not the neighbor's house, amazingly. But the power grid affects everyone because it's a grid. And so even though maybe your house or your community wasn't directly impacted by the event, you are going to be impacted by power loss, even though the event was far away. And that's because we have a national grid or a grid, a macro grid, and you don't control your own power independently like a microgrid provides. I was in Colorado, I think back in 2013, responding to floods you had there. I have a slide later about the number of power outages happened after those floods. I think what you'll find if you start to look at it like I do, because I'm obsessed, is like you read about an event that happens in our country, whatever the event is, and immediately the next line is, something happens, how many people are without power? Like you can't avoid it. It's the next thing because it matters so much. And the impact of that. In California, there's 180,000 people at home with medical devices at home. And if they lose power, those devices that need power can't be charged, et cetera. Skip through this. Florida, this is Hurricane Michael after Florida. Again, like the most important people I've realized after 15 years of emergency response, that the people coming to restore power are actually the most important. Obviously, the first responders and life-saving, but I mean, power is always very soon behind. And then in Puerto Rico, I mentioned we were delivering insulin in cooler boxes around the island for months and months because no one could keep their insulin cold. Puerto Rico has the highest rate of diabetes in the developed world. So a lot of folks with insulin to live. And it coalesced then that there was a better way to do this. Every health center on the island had a generator, but none of them had power. And so we started building microgrids, solar, battery, so that these health centers in Puerto Rico could remain powered and not rely on fossil fuel generation. This is just a picture I like. This is the heart is where Puerto Rico would be if you could see it, but that's how little power there was, or how zero power there was. You can't even see it. Over to the west, you can see Haiti, even though most of that country has no power, but Puerto Rico was that dark. And they found studies came out very recently about the impact of the power loss in Puerto Rico. And from space, they can correlate the duration of the power outage by like municipality to the death toll in Puerto Rico. So the longer a municipality was without power, the higher the death toll was in that area. And then I came home from Puerto Rico and came home to the Thomas Fire in California, which was then the largest in California history. It's now been surpassed like 5 times, but we evacuated for a month, had no power in our house, of course. And when you have no power, you also can't get fuel in your car. So we luckily had a car with fuel, and we weren't one of those people that didn't even have a vehicle or money in the bank to be able to evacuate. But it occurred to me, going from Puerto Rico to California, that this power issue is not unique to any certain geography. It wasn't a Puerto Rico issue. It's not a Florida issue. It's not a California issue. It's a nationwide issue. So we started to support, like I said, community facilities, understand, design, help install, finance clean energy, resilient systems so they can stay powered and serve their communities. And ideally then, save money to boot, help our planet to boot, retain and recruit staff who like to work at a facility that's powered by the sun or has EV charging. There's a lot of co-benefits, but we led the reason we started it was for the resiliency. So we work all over the country, but some interesting things about Colorado. It's that your impacts of disasters are high, 2% of the annual budget. You have renewable energy goals as a state, which is fantastic, and there are these adders. Well, I don't need to go into the adders, but a lot of Colorado does qualify as a low income to help support the cost of projects. And then again, there's just some headlines. That's on the bottom right, the floods. So again, that was the headline: floods, weeks without power. And there you are, 21st in grid reliability. This cold isn't your biggest threat. Other climate disasters might be. We talked a lot about heat, which kills more people than all natural disasters put together. And then you still have most of your power coming from fossil fuel, unfortunately, and going more renewable can actually improve the grid. So I think I'm going to breeze through some of this and get to so Julie, I don't know, you talked about how microgrid works from the start, so I'll just very briefly say that when we support a community serving facility, we really try to understand the goals of what are we planning for, what are we trying to back up, are we trying to ensure your whole building can stay powered, and for how long, or are there certain critical functions of the building we're trying to keep powered? Obviously, for a health center, we're trying to keep powered, if not the whole building, we're keeping powered the pharmacy, the refrigeration, what holds the vaccines, often the servers, so they can still do telehealth or telemedicine or call center, so they don't have to totally shut down, but they can still see patients remotely. And then we're trying to get as much solar on the rooftop or on the parking lot, to both recharge the battery when the battery is drained, which it'll power the building every day, but then also save money on electrical bills on blue sky, sunny days. So we model a system, design it, cost it, 20-year, show a 20-year analysis, how much carbon does it offset, things like that, and then talk through ways of payments. And that always is where it gets to be the trickiest, and that's why this funding program is so incredible for these facilities. This is like a 3-minute video about benefits of a microgrid to a health center or a community serving facility. Julia, can I get a thumbs up or down? Okay. Thank you.
Why do health centers need microgrids? Health centers have a responsibility to care for their patients, staff, community, and environment. Section 330 of the Public Health Service Act even authorizes health centers to provide specific environmental health services. Caring for people and the planet is what health centers are designed to do, and installing a microgrid is one way to do that can help in many ways. They keep your doors open. Microgrids keep facilities running during planned and disaster-caused power outages, so you can provide continuous care for patients when they need you most. Microgrids have financial benefits. Switching to solar has direct financial savings from reducing the amount of electricity you buy from the grid. With a microgrid, you can fix and continue to reduce your electricity costs for over 30 years, making planning and budgeting easier. And if you have a battery storing the energy you generate, you can sell your excess back to the grid. Plus, a battery helps you avoid indirect, uninsurable losses caused by outages. No more missed patient revenue and spoiled refrigerated medicines. There are individual benefits. The people health centers serve are often those most negatively impacted by climate change-caused disasters and health consequences, as well as bad environmental policies. It is especially important they are able to benefit from resilient, clean microgrids, and surveys show your staff will feel better working at a health center with green technology, thanks to benefits like energy security, convenient EV charging stations, and carport solar, which provides shade, snow coverage, and lighting. Microgrids provide community benefits. During major disasters and climate-related events, Resilient health centers prevent costly visits to the ER, reducing dangerous overcrowding. In some cases, they can serve as community resilience hubs and heating and cooling centers. Also, microgrids bring resilient jobs and job training to your community. And of course, there are global benefits. It's no secret the healthcare industry is one of the largest contributors to greenhouse gases. The industry can and should be a model of how we can do better. Microgrid-powered health centers could offset millions of tons of CO2 emissions annually, which equates to real change in global greenhouse gas emissions. Finally, microgrids bring something truly priceless: peace of mind. In past disasters, prolonged power loss led to more people dying than the disasters themselves. You won't worry about power going out during an emergency. Focus can remain on patient care, and patients can count on their health center being open when they need it the most. More frequent and longer power outages affect a growing number of people every day. The faster you secure your energy independence, the faster you're freed from a dirty, outdated, and vulnerable power grid. Until now, health centers have largely missed out on the benefits of microgrids. Collective energy is changing that. We are all connected, and it's going to take the collective.
Cool. So that's, you could replace health center for community serving facility, and I think most of that would still work. Even though it's not providing medical care, maybe directly it's providing food or water or a place for people to come and shelter or receive cooling or heating. So I don't think I need to talk about the Inflation Reduction Act much, right, Julia? Because that's I don't know how that interacts with your funding, so I'm going to skip that. And then, yeah, just a quick case study. This is a project we worked on in Louisiana. They were impacted, a large health center, 60,000 square feet, impacted by Hurricane Ida. They had a diesel generator. They even had a contract with a fuel provider to bring them fuel after when they needed it. And of course, after a hurricane, they couldn't get it. And sadly, they couldn't. So they ran out of fuel. They had to close. Impact on lower Ninth Ward in Louisiana on the patient population was huge. On top of that, they lost $800,000 in revenue from a 3-day closure. And so it's a direct financial hit as well as a community hit. They now have full solar on the roof. This was an early shot, a backup battery. And they've swapped out their their diesel generator to a natural gas generator because of that issue of unreliability of getting diesel. It's like in a natural disaster, the hardest thing you can get is diesel. So diesel generators don't often make the most sense. And then just say, like, there is a lot of funding out there, including this one and amazing in Colorado, but like there's a lot of federal money that's supporting these types of projects, especially for community serving facilities, especially serving vulnerable communities. And so just plug to kind of at least look at it. If you looked at it in the past, things have changed. As my hero Bill McKibben says, that we've now come to a place where the cheapest way we can produce energy as a planet is to take a big sheet of glass and point it at the sun. So solar costs have come down, battery costs have come down, the reliability has gone up, and the federal and state funding opportunities have gone way up. So I didn't just encourage a look at it or a planning grant for those who are looking at it. And I'll stop there.
Thank you so much, Andrew. All right, well, that is what we have. Do folks on the call have questions for anyone? Yes, Beth.
I'm sorry, Julia. I always have a question.
That's great.
So on that picture that Andrew showed of the rooftop from New Orleans, I can see the solar. Are there batteries on that rooftop that I just don't know what they look like? Or because what I'm trying to think about is, I've got 7 fire stations in my county. Can I put a battery on all those roofs? I've got a health clinic, one in my county. Can I fit this stuff on top of that roof? That's what I'm
Great
trying to,
question.
I don't
Yeah.
know what physically it looks like.
Sure. Yeah, it's a great question. I had a slide I took out that shows the battery. So, Julie, I'll answer if that's all right. But no, so the battery we don't put on the roof. It's pretty hard. They're so heavy. You'd have to design a structurally with a new building to fit a battery on the roof. So where we do, we find a battery outside the building. Actually, it's preferred to be outside, kind of as close to the electrical room as we can get it. It's it looks like a industrial size refrigerator, basically. It's vertical, 8 feet tall, 4 feet wide. It's on a concrete pad bolted to the ground, and it's fine outside. It prefers to be outside, actually. So the worst case scenario would take up like one parking spot for a frame of reference.
So it can take up the spot that my big giant generator is sitting on?
Yeah. Yeah.
Okay. Awesome. Thank you.
Great. Anybody else? All right. Well, I appreciate everyone's time today. We'll be, saving this recording, posting our slides. I'm sure we can email them out to you guys as well. Yeah, just thank you so much for coming and learning with these great presenters, and feel free to reach out to us if you have any questions. So thanks so much. Have a great day.